The last talk in this section before the Q&A is by my friend and colleague Julien Edeline from Nantes, who's going to tell us about the value of SIRT for intrahepatic cholangiocarcinoma. Welcome, Julien.
Thank you very much for this kind invitation to discuss a new potential treatment option for patients with biliary tract cancer, and I will focus on intrahepatic cholangiocarcinoma because it's clearly the population that could benefit for SIRT. Well, just a few words, we already discussed that, but we know that intrahepatic cholangio is the type of cholangio that is currently rising in worldwide and especially in Western countries. We already discussed that probably because of better recognition, especially versus CUP or also versus HCC, and also probably related to the increase in risk factor for liver disease. So we see more and more intrahepatic cholangiocarcinoma patients, and trying to improve treatment in this subgroup of patients is, of course, important. The standard of care for intrahepatic cholangiocarcinoma patients followed those of all-comers biliary tract cancers. And we mainly treat them according to the standard of care chemotherapy with cisplatin gemcitabine. And we know the results in the all-comer advanced BTC. But it's important when discussing potential benefit of liver-directed treatment for liver-only intrahepatic cholangiocarcinoma patients to focus on the results in this subpopulation. And Angela previously reported results in this subpopulation suggesting that patients with intrahepatic cholangiocarcinoma with liver-only disease might have overall better outcomes than all-comer advanced BTC. And we should keep these figures in mind when we think about the potential role for liver-directed treatment. So what is the current evidence for SIRT for intrahepatic cholangio? Just first of all, to present briefly what is SIRT. SIRT is a liver-directed treatment. It's an intra-arterial treatment. Patients should undergo an angiography, which is a radiologic intervention. And we catheterize the hepatic artery, and then we can deliver different treatment. With SIRT, we delivered microsphere that has been loaded with a radioisotope, most frequently yttrium-90, and that provides a local irradiation of the tumor. This has been mainly studied for hepatocellular carcinoma, but after initial positive results with HCC, it was also tested for other patients, including intrahepatic cholangio. So for quite a while, we had multiple retrospective studies of SIRT for HCC. But the quality of the evidence was quite limited because most of these publications were single centers with quite a few patients, some case reports to 100 patients. Also, it's very difficult to interpret the data because the population included is very heterogeneous. Patients might have been treated as first line treatment, the first treatment applied for this patient, or in later line, including patients refractory to multiple chemotherapy regimen. And obviously, the results will be better in first line versus later line. Also, the extent of the disease might lead to different efficacy in a liver-directed treatment. And some patient has a unilobar, one half of the liver is involved, and some people have both sides of the liver involved. And of course, when we do liver-directed treatment, it's easier when only one side of the liver is involved. So overall, the results in this series were quite heterogeneous with different response rates and very different survival for this patient, which make it difficult to know whether there is a real impact of the treatment. But from this early series, we did see some interesting thing, and I noticed that SIRT was discussed with the hepatology surgery talk this previously. And indeed, when we started to apply SIRT in intrahepatic cholangiocarcinoma patients, we did see quite frequently some shrinking of the tumor that make us discuss again with the surgeon whether this patient could be resected following our treatment. In our first series of patients, quite a few can be secondarily resected by our surgeons, which might, of course, be very important because surgery is the only treatment with curative intent. Just to illustrate that, a patient that was affected with a large single intrahepatic cholangio, and frequently it's in the middle of the liver, quite difficult to resect. In this patient, we had left portal vein invasion, but also contact with the right portal vein, which make it impossible for the surgeon to resect. We applied a combination of systemic chemo and SIRT, and we did not see a major shrinkage, more necrosis, but we do see some margin appearing between the tumors and the right portal vein, which make it discussed with the surgeon again, and indeed the patient have been resected with a left extended hepatectomy. 1 year later, this patient recurred with a single small liver lesion that we treated with radiofrequency ablation, and currently this patient is still free of the disease, illustrating that we can put the patient back in a curative track if we can shrink some initially unresectable tumors. When we did see these patients that we were able to resect after neoadjuvant treatment, we wanted to know whether these patients could have long-term survival. And we compared the outcome of this patient treated with a neoadjuvant approach with patient resected up front. And this is a surgical series. The blue line is patient with intrahepatic cholangio that can be resected with a initially resectable tumors that were resected up front. We had quite similar result as other series. In yellow, we had patients that were initially unresectable and had chemotherapy and then resection. And well, survival was something similar, initially resectable patients. And we finally compared with patients initially unresectable that were made resectable with the use of SIRT plus or minus chemo. And reassuringly, these patients do have quite good survival. So if we do see a shrinkage that can lead to discussion to surgery, yes, we should proceed to surgery in these patients. And even more when we try to analyze with taking into account the fact that these patients initially have had larger tumors, more multifocal disease than patients with initially resectable tumor. When we stratified about this risk factor, we did see that in multivariable analysis, patients treated with a neoadjuvant approach had better outcomes than patients resected upfront. Of course, this is retrospective data that doesn't prove, but still it's suggesting that this approach might be interesting. Just a summary of the retrospective clinical evidence. So there is some evidence for activity of the treatment. The best population, clearly intrahepatic, is important. We had better result in case of lower tumor burden, especially unifocal, unilobar disease. Probably using this first line can improve the chance of future resection. And clearly, we try to discuss this local regional treatment, especially when we might think that patient could go to surgery if we can downsize a little bit the tumor. To improve the level of evidence, we performed a prospective clinical trial. This is a MISFACT trial, a multi-center single-arm phase 2 trial. We included 41 patients in 7 French centers. We, in this trial, performed a combination treatment with both the standard of care chemotherapy using cisgem and a combination with SIRT. In patient with unilobar disease, we performed 1 SIRT session. In patient with bilobar disease, we performed 2 SIRTs. The characteristic of the patient are here, just to say that quite a lot of these unresectable patients had, in fact, cirrhosis, 29% of our population. In 2/3 of the cases, we had only unilobar disease. The primary endpoint was response rate, the percentage of patients who do see a significant shrinkage of the tumors, and it was 39% response rate, which is believed to be higher to what is expected with chemotherapy alone. But maybe more strikingly, the disease control rate of 98%, which is very much higher to what is expected with chemo alone. And we did see quite a lot of necrosis, even in patients that did not have shrinkage. Some patients had necrosis of their lesion. The secondary endpoints are also quite important and promising. We had a median progression-free survival of 14 months and median overall survival of 22 months, which is suggested to be better to what is expected with chemo alone. Probably the more important thing for me is this proportion of patients that can be downsized to resection, with 22% of the patients that can be directed to surgery with curative intent. And as you may see, some patients have long-term survival without recurrence, suggesting that they might have been cured for an initially unresectable disease. About the toxicity, most of the toxicity were hematological. However, we did see in cirrhotic patients quite an increase of liver decompensation, more than what is expected with either SIRT alone or chemotherapy alone. And we believe that combination of both in cirrhotic patients is too risky, and we should select either one or the other. In conclusion, for this MISFACT study, we showed that there is activity of the combination of SIRT and systemic chemotherapy. It's feasible in most patients, but not feasible in cirrhotic patients. Quite high response rate and very high disease control rate, and a significant proportion of patients that can be downstage to surgery. Of course, this is single arm, so we should have randomized evidence before being sure that there is improvement of the outcomes. We tried to approach this comparison And we tried to match the patient treated in the MISFAC trial with a combination of systemic chemo and SIRT, with patients treated in other prospective clinical trials, the UK ABC 123 trial, the French Bingo and America trials. And we selected in this population patients with intrahepatic cholangio without extrahepatic metastasis. And we compare them by matching with scores to have patients that can be compared. And this analysis do suggest that SIRT combined with systemic chemo might improve outcomes in terms of overall survival and progression-free survival. For overall survival, we had from 15 months median to 21.7 median, so suggestive, but still no randomization, so it might be prone to unknown bias. Recently, there has been a second prospective trial conducting in Asia, multi-center, with a bit slightly different strategy, starting with SIRT and then followed by chemo, systemic chemo, initially with a 1 month delay, and then they reduced the delay. 24 patients included, with only 17 that could be treated with both SIRT then chemo. And in these patients that received the full protocol, overall response rate is 25%, disease control rate 75%, median PFS of 9 months and median overall survival of 21 months. And also suggested that patients that cannot receive chemo had poorer results. That clearly suggests that the concept of combining with systemic treatment is important, and indeed systemic chemo is the most validated treatment option for this patient. So we should use SIRT in combination if we want to apply some local regional treatment. So recently, local regional treatment have started to be included in guidelines. And for example, the recent ESMO guidelines do propose for patients with locally advanced liver-only intrahepatic cholangio as an option, local therapy might be applied after treatment with systemic treatment. There are some other prospective clinical trials, and I think it's important to have randomized trial. An important trial was the CIRCA study, a phase 3 multicentric international study comparing systemic therapy alone with SIRT followed by systemic therapies. However, this trial closed earlier due to somewhat slow accrual, but about 100 patients were included. And even if we don't have the full accrual, there will be some important result from this trial that we are waiting for quite a few years now, but hopefully we will have them. In France, we are conducting a new trial, the SIROCO trial. This time, we move forward to neoadjuvant treatment for patients with operable intrahepatic cholangio. So this is a multicentric randomized phase 2 trial. Patients with intrahepatic cholangiocarcinoma with some high-risk features, large tumors, multifocal, slight resection margin, are randomized between the standard arm, which is trying to do surgery upfront and providing adjuvant CAPE, with an experimental arm with a combination of SIRT and CAPE before surgery, with the objective to improve the rate of surgery with adequate margin. There are also single centers prospective trials still going on. So in conclusion, is SIRT an option for intrahepatic cholangio? Well, There are multiple retrospective series confirming activity, suggesting safety. We have now prospective data confirming these initially promising results, but there are still numerous unanswered questions. What is the comparison with other local regional approaches in other countries? Intra-arterial hepatic chemotherapies is proposed. Other intra-arterial chemoembolization is proposed in other countries. We do not know which is the best approach. The main question is whether we will find superiority over standard of care systemic chemo, and we need randomized data. Currently, immunotherapy is in the first line, and so we need to combine. The ideal population, I think, of course, is patients that would be considered borderline resectable. The surgeon feels that it's a bit too difficult right now, but if we can shrink a little, we might think these are the base cases to consider local regional treatment. I thank you for your attention.